right, great. All right, welcome everyone. So happy to be here today. Telehealth is one of my favorite topics. I'm so glad to be partnering with the Northwest Regional Telehealth Resource Center to bring you this content. And this is really about person-centered telehealth, and we've kind of toyed with the title on this, Mastering the techno-human aspects of telehealth, because there's so much to delivering telehealth that is a bit of a departure from in-person visits, but then a lot of the same principles come into play for telehealth visits. We are offering CME for this webinar, and all of us on the line today are very clear that we have no relevant financial relationships to disclose, and you may hear me mention a telehealth platform or two, and just know that all of us on the line today are vendor neutral. So if I mention Zoom or Doxy.me or something else like that, it's really just, I'm being vendor neutral. It just happens to be, I have to name a name, so that's the way it is. So today, it'd be really great if we can spend the next hour or so looking at ways to optimize person-centeredness for the full spectrum of telehealth visits or televisits. And by person-centeredness, we're not just talking about patient-centeredness, it's the staff as well. So when I talk to a lot of our rural clinics, our rural health clinics, for example, they don't always have the supports for the clinicians. And so clinicians are trying to do a telehealth visit, trying to sort things out on their own. And we do have some great best practices where practices will engage in training or have somebody at the elbow of the clinician helping them and supporting them until they're totally familiar with whatever platform they're using. And really think about patient-centered workflows. So, when we have our in-person visits, we're great at doing team-based care, doing advanced care planning, having huddles, and then with telehealth, things just kind of seem to, fall by the wayside. And let's talk a little bit about what threats there are to quality and safety and what we can do to keep patients safe. So going to go through this pretty quickly. So for terminology, there's the technical definition of telehealth, which is really an umbrella term. And then there's a practical definition of telehealth where CMS has a discrete set of services that they define as telehealth services. And then telemedicine is a subset under that umbrella. Is telehealth, that practical definition, the specific set of services, and then virtual services as well. We're really going to focus on telehealth today. You'll see that on an upcoming slide. But there are virtual services that don't fall under those discrete set of services. There's, for telehealth, the originating site and the distant site, which is always important to keep straight. The most cited definition of telehealth that I see is from HRSA, and it's just a really great comprehensive definition. It has that umbrella in there. So, even professional health-related education fits under telehealth technically. So we're really going to talk about telehealth. The other telemedicine options include the telephone E&M option that's available only to us during a public health emergency, the virtual communication services, which we now have additional options with virtual check-ins, also the remote evaluation where you can maybe take a picture of a skin lesion and send it to your clinician, e-visits, which I honestly don't see a lot of people doing e-visits. I hope they take off a little bit more. Remote physiologic monitoring or remote patient monitoring, chronic and principal care management, which we should be doing more and more of, behavioral health integration and co-management of psychiatric conditions and interprofessional consultation. So we're really going to focus on telehealth today. So before the telehealth visit, like way before, what are the supports that we can provide to patients? How do patients know their options? So when I work with practices, I'm a practice facilitator and I provide practice facilitation on a broad range of topics, everything from what are your scanning workflows to how are you optimizing your telehealth visits to how do we do team-based care, and anything in between, anything related to frontline service delivery, I provide practice facilitation for. Telehealth is now the bulk of what I do and is really exciting. So I do work with a fair number of organizations, and whenever I work with a new organization, I go to their website and I pretend I'm a patient and I look to see, if I'm a patient, can I tell what the options are? So can I get a telehealth visit? Does the practice offer remote patient monitoring? How do patients know what their options are? What's the standard scripting when patients call to schedule an appointment? I had to schedule a telehealth appointment recently, and I was told that they were only giving in-person visits. I'm like, really? You aren't doing telehealth? And they said, nope, you have to be in person. I said, okay. So I went to that in-person visit, and you can best believe that I asked the clinician, I'm like, why are you not doing telehealth visits? And he's like, oh, we're doing telehealth visits. I'm like, oh, okay, well, you might want to tell your reception staff that. So, what is the standard scripting that your receptionists are telling patients when they schedule an appointment? Are they offering telehealth visits? Are they kind of trying to steer patients to in-person visits? Are they letting patients know when perhaps a virtual check-in is a little more appropriate? And unless you provide that standard scripting to your reception staff or whoever's doing scheduling, they're not going to know. It's also a great opportunity. So when a patient is calling to schedule or ahead of time, before they're scheduling, to let them know what the expectations are. What we're hearing from clinicians is that a lot of patients will be grocery shopping and they'll take a telehealth visit, or they'll be walking down the street, or they'll be driving. So setting those expectations, when and where are the juncture points where you can set the expectations and say, treat this like an in-person visit. I was working with a long-term care facility, and when they are scheduling telehealth visits, they have to schedule around the patient's activities, because they don't really like being pulled away from their favorite activities when they have to take a telehealth visit. But what I heard, and it was actually so charming, was that even though somebody might look dressed from the top up, some of the residents said, well, I want to put my shoes on because I really want to be prepared for my visit. So, they're really this is very much like an in-person visit, but set those expectations for patients about what a virtual visit or a telehealth visit is going to be like. Pretend like it's an in-person visit. Do everything, kind of along the same lines that you do for an in-person visit. And, we always say that people need to hear things 7 times and in 7 different ways. So you can't just say, oh, I told the patients, or it's on our website, so, they should know. People just need to hear it 7 times over. And I find that because we're in the pandemic, people tend to be a little distracted. So maybe you need to get the word out in multiple ways. So, is it on the website? Do you have a patient sheet? Do you have FAQs? Just earlier this morning, I went to Practice's website, and they had great FAQs put together. You can have posters in clinics. So if somebody does have an in-person visit, they can see that there is this other option in the future. And I'm really hoping that telehealth stays as an option beyond the public health emergency. Even though telehealth has been around for decades, we haven't really leveraged it or used it like we can as we are in the public health emergency. Patient partners are great. So having a patient partner who can talk to other patients about telehealth visits and how it's worked for them, or to have testimonials that you might put in a poster, can be really helpful. You can put it on your on-hold message. I haven't actually found any clinics that have, due to my limited experience with calling patients, I have yet to hear an on-hold message that says, oh, did you know that you can have a telehealth visit? Your reception staff can be giving the message. One of my health centers that I work with in Los Angeles actually did a text campaign out to all of their patients to say, and they actually did this way back in March, they had amazing engaged leadership. And so leadership kind of took control and said, let's get these in-person visits rescheduled, and they sent out a campaign on, they have a ability to send it right out of their EHR, and they texted everyone and they emailed everyone what the options were. And so, you know, the other piece that I think that, especially in primary care, we're kind of missing the boat is thinking about empanelment. So if you're doing anything around PCMH or the patient-centered medical home, or you're getting recognition as a medical home, you will have to do empanelment. So I'm a clinician by training. I used to be a clinical manager, and we did empanelment at my clinic. And you know, I would want to know, if I were still in practice, I would want to look at my panel and identify all patients who were at high risk of contracting COVID-19 or having adverse outcomes with COVID-19. I would be calling them and saying, let's set up a telehealth visit. I would be talking to them about redoing their advanced care plans, you know, really being proactive, because that's what primary care is all about. You know, we're not acute care. We don't treat them and treat them. And so taking a proactive outreach and leveraging telehealth to contact with patients. I'm also really worried about with COVID-19, with patients not coming in to be seen in person, that we have, that we're going to have delayed care because people aren't going to call, they're going to put things off. And so doing proactive outreach and contacting people. And, you know, if somebody is due for an annual wellness visit, for example, if they're patients 65 and older, we should be scheduling telehealth visits and doing that by telehealth, because annual wellness visits are covered. I also hear a lot of terminology about educating patients and literacy. So I think on this other slide, I had a text box, you know, words matter. Consider patients need to be educated about telehealth versus how can we best support patients with telehealth. So just being person-centered in our terminology is really important. And, you know, we worked on a project with several low and middle income countries, and we put together resources, and they would not let us use the word patient. Patient really harks back to paternalistic medicine. And so using more person-centered terminology about them, talking about individuals in Alaska, that Indian Health Services, for example, is very respective, and they call them clients or customers. I struggle to get away from using the patient terminology, but I will always put a plug in whenever I can. And instead of educating patients, we support them, because if they're not educated, what does, you know, if they need education, you know, what's the flip side? What does that mean? The same with literacy. If we say that they don't have good technology literacy, you know, what does it mean if they don't have it? They're illiterate. You know, it's just, I just want to put a plug in for when you're putting person-centered materials around telehealth together, to really think about how you're using the words and make sure they're really respectful. So, you know, we talk about possession as 9/10 of the law. So before the telehealth visit, patients need to have certain things in place. And just a really, really simple question. Do you have a smartphone, tablet, or desktop computer with a camera and internet or some other way to connect? Asking them that. And if they have one of the three, we can consider them video capable. And another important piece of telehealth and delivering telehealth visits and virtual visits is quality improvement. So if you document this and you document it as structured data, you can run reports to see who could have a telehealth visit and who cannot participate in a telehealth visit. One of the rural health clinics that I'm working with, they have patients individuals who don't have the capabilities to engage in a telehealth visit. And what they've done is they have a nurse who actually goes out with a tablet to the patient's home to be sure that they're not missing care, because they're either homebound or they can't get to their visit, or they're afraid to come to their visit. And so by asking that question, knowing who possesses what's needed for a telehealth visit can be really important in managing the population, doing population health management. And honestly, I'd say it's a social determinant of health. So I love telehealth. I'm a huge fan. But So it has expanded access, but it has also exposed a lot of equity issues that we should have been able to foresee ahead of time. And I keep thinking about what are the solutions, how can we kind of level set that equity so that everybody has the same access to telehealth visits, and certain people don't have to risk their safety to come in person because they don't possess those things that you need to have a telehealth visit. We are looking at some possible work in the state of Washington to expand community options to ensure video capability around telehealth. So, wouldn't it be awesome if public libraries or the YMCA would have a dedicated telehealth room with the necessary equipment for an individual to take a telehealth visit? We also think that employers have a great opportunity to provide what's needed for a telehealth visit. We have, as part of our Patient and Family Advisory Council, we have people who own, for example, a construction business, and they're like, yeah, Trudy, that sounds really great, but we're a construction company, and we can't have that really nice little room for one of our employees to take a telehealth visit. But there are some employers who can accommodate that, and we can really expand access. Deliver tablets to patients that lack them. So there are some organizations that FedEx tablets to patients so that they have them. And they sometimes, and I honestly don't know how that works. I'm assuming that once the patient is done with the tablet, there's an easy way for them to send it back, or somebody picks it up. I can foresee issues with that. But I think with select patients, that might be an option to get devices to them. People are doing it. On-site support for high-risk patients. So like the Shoshone Family Medical Clinic in Shoshone, Idaho, they have that additional support for high-risk patients. And I want to pause for a second. I really would rather not just talk didactic and talk to slides and content. We know that I'll teach, I'll learn is much more fun. People like to hear from each other more than they would hear from somebody delivering a webinar. So, possession and getting what's needed into the hands of individuals to have a telehealth visit, what else can you think of that might be helpful to facilitate the ability to do a telehealth visit? Like, what are your creative ideas? Feel free to unmute. And while you're thinking about that, I want to launch a poll. It's an easy peasy, one question, yes or no. And the poll, so start thinking, doesn't require a lot of brain power, but have you had a telehealth visit? So when Matt, Jaylene, and Nikki and I joined the webinar early, we were talking about, have you had a telehealth visit? Yeah, sure, I've had a telehealth visit. Well, what went well, what went not so well? And so we'd like to know whether you've had a telehealth visit or not. So it's an easy question, and just answer yes or no. We have set this so that the responses are anonymous. So, you're not gonna violate privacy or anything just by saying whether you've had a telehealth visit. And I would love it if we have some time to discuss what could have gone better. So, for example, when we were, before the webinar actually started, Matt said he had a telehealth visit and he got kind of put it on hold for 20 minutes. I mean, the equivalent is when your provider is in clinic and running behind and you have to wait. And 20 minutes is annoying, but sometimes you're stuck for an hour. But if you're using your smartphone for your visit, it's like, I can't do anything else. I can't check email. I can't text anybody. I can't talk to anybody because I'm waiting for my telehealth visit. It can be really not the easiest. It's looking like 8 out of 10 people, yes, you've had a telehealth visit. So I have a sense that you bring a wealth of information about what we can do to improve our person-centeredness with telehealth. And let's see. You should be able to unmute yourself. So anyone who says that they have had a telehealth visit, do you care to tell us how it went?
So good morning. This is Tammy Arn. I'm with Northwest Telehealth in Spokane. I know a lot of you, so hello. Did have a telehealth visit. It was a specialty provider, which again, you want to say to yourself, thank God I can see a specialist via telehealth. So you forgive all things. Somebody from my perspective who facilitates how to do this was surprised in the way that we received the link and clicked on it early as per direction with nobody who ever showed up. Finally called the office just at the top of the hour, knowing that somebody, in my opinion, should have joined in to say hello, welcome, the doctor will be right with you, to find out that, oh sure, just hang tough in the waiting room and they'll get there. The waiting room was identified appropriately, so that was good. But the specialty provider was running late, over a half hour, but we waited, and then we were given ample time for the consult, which made up for all of that. So to me, in this perspective, I think you forgive a lot because you're so grateful to be able to be seen, right? And so I think that is that's one piece of it. But I found myself, from my perspective, thinking, well, this is how you should do things differently, right? In terms of the patient-centeredness of it, it was, click here and hope that it all works out. Luckily, I completely knew how to do it, but I just think it's an assumption that leads to failure in many cases.
Really great contribution, Tammy. Thank you so much. And I wonder, did they follow up to find out how things went? I mean, did you have a chance to tell them your experience?
No, nobody followed up with it. Again, I think that when it's a healthcare issue, that's the primary thing that you're focused on. And I'm just interested in it because that's what I do. And did not follow up with anybody at the office about my experience. These are people we do work with professionally. So I think it'll be an interesting conversation at the right moment of time in the future. But it's certainly, again, I think that this is a provider group that is responding to COVID and the way things are delivered today, and especially if it's a compromised patient who struggles to get into the office, and not so much a polished, here's our virtual care, express care kind of delivery where somebody greets you and is there. So I think there's this dichotomy of here's how we're doing our virtual care as an organization, and then those provider groups are, here's what we're doing to accommodate this request in today's world.
That's awesome insight. Thank you. Anyone else care to share how their telehealth visit went and what opportunities might have been taken to make it more person-centered?
Anita, I think you might be muted. Sorry, appreciate it. I'm going between computers and I unmuted the wrong one. But so I had a telehealth visit with my nurse practitioner. It was pretty clear that, I insisted upon it. And this was like, April, no, it was in the summer. So it wasn't too far into it, but she said, oh yeah, we do that. I had to schedule it with her nurse because the nurse was going to triage. So I had to take days of playing phone tag with the nurse practitioner's nurse who was scheduling. So that was, frustrating, particularly when you have something that you wanted addressed immediately. And she said she wouldn't continue one of my medication I had been on for 6 years because I wasn't there in person, even though we had the telehealth visit. And then she when she was talking, she turned and was typing. So what that meant was I couldn't hear everything because her voice was projecting, and it was emphatically clear that she's pivoted to this and was not at all happy about it. I mean, that was very clear. And I have a new nurse practitioner now. So, I mean,
Wow. So it was a
I'm
deal
not
breaker.
tolerant of people who and so I have two new healthcare practitioners who they were adopting this, not even bothering to do the most minimal things, because I'm just doing this because, just to stay alive right now as a business. And I've spoken with others who have had comparable type of experience. And the problem becomes, if you're not familiar with telehealth, you think that's what it is. And so I feel like all the work that we've done to put out how positive telehealth is, when you have practitioners who during this pandemic have done this, but only pivoted to it and begrudgingly, another practitioner, I mean, about every 50% of the time, her connectivity wasn't working. And she didn't seem to understand that it's important to charge your computer. It's important to have access. I mean, all of this, she said, well, it's because of the time of day and I share with somebody in the building. I don't care why it is, fix it. I mean, so unlike like Tammy, I'm not particularly tolerant of those that are not, at least I'm fine if it's a bumpy path to get there, but at least try. So I mean, that's how I felt as a patient, and also working with the TRC. If it was, gee, I'm working on this, blah, 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 that's one thing. But this was just kind of like I said, this was not thinking about the patient at all. So.
That's great. Thank you so much, Anita. Those are really great points. I actually had not thought about that as a best practice for a clinician. If you're turning your head to look at another screen to document, you might lose some of the clarity of your audio. We have heard from our patient and family advisory council. We asked them about telehealth visits, and we asked, is it annoying when the clinician doesn't have eye contact with you and they're looking away to document? And they said, no, they do the same thing in person. It's just helpful when they tell us what they're doing, because we can't see what they're doing now. So we don't know, are you checking email? Are you documenting in my chart? So just kind of telling patients what you're doing can be a best practice for person-centeredness. And we'll get back to hearing some individual stories with visits if we have time at the end. But in the meantime, post into chat what your experience was, maybe the pluses and the minuses, and what you would change if you could redo it again. So, before the telehealth visit, make accommodations. So there are, as I said, we now have kind of equity issues that are being brought to light because of telehealth. So you should know whether the person that you're going to be seeing has a hearing impairment or a vision impairment. And that should be part of pre-visit planning, honestly. That should be noted in the patient chart. I'll just tell you that clinicians are not so good about documenting if somebody has a hearing issue. And there are ways to do that in a structured way. I mean, you can use that as an ICD code that you put into the problem list. I think the medical term might be something like presbycusis, but there is an ICD code. So knowing whether your patients have hearing, have impaired hearing can be, you can turn the volume up, you can make sure they can hear you, can check in. I worked with someone who I had a meeting with her, and the second meeting she said, I have a hearing impairment. And so I basically shouted from then on for our follow-up meetings. And I didn't mind that. I mean, I was so relieved that she told me, but there's some sort of stigma around it. And so people are a little hesitant to tell you. So sorry, off on a little bit of a tangent. So know whether your patients have a cognitive impairment for whatever reason. I remember seeing patients with cognitive impairment, and I often knew and had made arrangements with the spouse because I would call them after the visit, or I would make sure I had a really detailed after visit summary that he or she could take home to their primary caregiver or spouse. So this telehealth provides an awesome opportunity for other family members to join a visit. So if somebody has cognitive impairment, there are certain things that you can do to make it easier for them, especially if you're doing telehealth visits to nursing facility residents. There's things we can do that, to accommodate them, and often having another person present. I feel like I speak pretty clearly and pretty loudly, but I have had patients with cognitive impairment. I would say something, they would look at their spouse would say the same thing I just said, but it would click because I think their brain was cued to that person's voice and not my voice. So if you have to do something like that in a telehealth visit, you may need a little extra time. Language and translation needs. I work with, like I mentioned, some health centers in Los Angeles. One of my practices, something like more than 50% of their patient population doesn't speak English. And so they have to do everything around the telehealth visit. So not only kind of during the telehealth visit, but they have to, when they send out instructions for how to connect to the telehealth platform, it has to be in the patient's preferred language. And they have something like 20 languages that they have to accommodate. So making sure that people that we're accommodating are non-English speakers, or those for whom English is not the first language and they have a different preferred language. So by now, most healthcare organizations should be documenting patients' language. And so, is there a way for you to accommodate that? Sometimes it's actually been, I hear from clinics that it's actually easier to get a translator. Zoom, for example, has a translation. Like I said, I have to be vendor neutral, but I happen to know that Zoom has translation for many languages. And when I've looked into the cost, it's less than actually paying a translator. So limited digital proficiency, there's a learning curve. So if this is someone's first telehealth visit, they may need a fair bit of support. Whereas if this is their third or fourth or 10th, it's like old hat to them, they'll be fine. So, what are some solutions to accommodate people? So having those non-clinician caregivers or patients or family members, and it can be platform specific. So one of our rural health clinics that we work with in Idaho switched from Zoom to Doxy.me because Zoom was just problematic for the patient. You had to have the app. It wasn't easy. I mean, sure, you don't actually have to have the app. You can copy and paste the URL into zoom.com, but it was difficult for patients, and Doxy.me was easier, so they went with Doxy.me. Healthcare ambassadors. So some practices have healthcare ambassadors who join the visits, have practice visits. So if somebody is new and they're nervous, it can be really reassuring if you offer them when they schedule, would you like us to do a practice visit with you either right before your visit or, anytime that's convenient for you? Do you want to do that now? And walk them through what it's like. And sometimes you just have to say, for this patient and for the accommodations that they need, maybe this is part of our triage for who needs an in-person and who needs a telehealth visit, and this person just needs to have an in-person visit. So if you can think of any other accommodations, I'm always one for capturing the wisdom of the crowd. So if there's anything else that you can think about for accommodations that are needed before the telehealth visit that we can anticipate and meet people's needs, it would be great if you could put that in chat. Backup plans, and make sure they're written. So for our webinar today, my backup plan was I sent the PowerPoint slides to somebody else. So in case I had to switch or, my power went out or internet failed, make sure you have backup plans. So what happens if the patient doesn't have the link? They can't find the link. I've talked to some of my health centers who try to talk patients through. They're like, we texted it to you, and they can't find it in their text, or they can't find it on their email because they've, got so much junk email. So what happens if you have a telehealth visit and you're ready to connect with your patient and they don't have the link? How is it sent? One of our rural health clinics, the link for telehealth is sent to the portal. So, if a patient doesn't have access to the portal, this can be a challenge. They don't have email, or they don't have a way to check email. So not everybody has a computer or a device to check email. I know all of us on this call probably do, but if you only can do your telehealth visit on your smartphone and you don't have email, or you don't have email set up on your phone, and we're emailing you the link, that's just not going to work for patients. One of our rural health clinics, even for some patients, the reception staff, letter by letter, they spell out the link for the patient. So, what's your process? Can't connect? Oh my gosh, this happens all the time. How are you going to troubleshoot? So, you just have to be creative. You have to know the most common problems that come up with you, your providers, your platform, your patients. Poor audio quality, yours and theirs. Like, how many Zoom calls are you on a day, or virtual meetings where all you hear is wah, 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 wah? It reminds me of that Charlie Brown cartoon, or when you drive up to fast food and you can't hear, or you get that robot voice. What's your plan for it? So if you're on an internet connection, is there a backup for doing a phone call? And to make sure the patients feel comfortable saying, I can't hear you, or I can't understand you, is really important. Checking in with them. Can you hear me okay? What do you do with emergency situations? Do you have a plan for calling 911? This does happen. You can be seeing a patient, and they may be, the reason in the visit for you as a clinician is back pain, and you start talking to them, and you find out that they have anxiety or depression, or they're suicidal, or you have somebody who should not have had a telehealth visit because you call them and you see they have crushing chest pain. And if you need to call 911, what's your backup? What's your written plan and your process for documenting exactly where a patient is when you have a telehealth visit? Like, if you ask the patient, where are you? Well, I'm at home. Do you have that home address? And so just kind of verifying and documenting in the chart where that patient is in case there's an emergency, and build in that time that you need, assuming that first session is going to be a little, what I call techno bumpy. You may need a little bit of extra time, and you may not want to use clinician time. So do you have a dedicated member on the team who can kind of get the patient up and running for the clinician to then slide in and do that telehealth visit? And we were on an echo session the other day, and those handoffs of, doing team-based care, and how do you hand off to somebody else? So if you're a primary care clinician and you're going to hand off to a behavioral health provider, how is that going to work? Because if you're on your device and you hand your device to the behavioral health specialist, how are you going to do your next visit unless you have a backup plan and you have a computer that you can go to, or a different device, or, you have the behavioral health clinician actually call the patient. So there are all kinds of backup plans to be sure that you stay person-centered, and patients don't get the sense for the chaos and disruption on their side. This should be smooth. This should be about them. This should be about their needs, what they need, not about the technology and what we need to do. So, in real estate, they say location, location, location. And in telehealth, I say workflow, workflow, workflow. We heard from Anita and Tammy about how the glitches in the workflow affected them, and also from Matt. So, having somebody on the line for 20 minutes is not the ideal workflow. So, you know, an ideal workflow, for example, for Matt would be Dr. So-and-so is running behind. He'll be able to get to you in 15 minutes. We can text you in 15 minutes, and then you sign into your visit. So just really think about how optimized your workflow is from your patient's perspective. So we always say walk a mile in their shoes. I don't know why, but we seem to have a blind spot with this. I just don't know what it is. About 7 years ago, I worked with 29 Harvard practices, and we were working on a project to see what the barriers to care were. And so we asked them to talk to 5 patients. And they were like, can we do 1? I'm like, no, 5. And then they asked, well, instead of talking to them, could we like maybe have a form to fill out? I'm like, sure, fine. So I developed a form for them. And then the next question was, could we have a student do it? So I'm just saying that even if you're Harvard, we just have this blind spot about checking in with our patients and seeing what their perspective of telehealth is. And for the staff as well, you know, we still have a lot of clinicians who just do not want to do telehealth. We have lack of buy-in, we have fear, we have change management. So how do we make it easy for our staff to make this change? And how do we make sure our workflow doesn't, you know, we've kind of heard from at least 3 or 4 people now about how their telehealth visit was. How do we make sure that that doesn't happen? Because it doesn't have to happen. If our workflows are good and we're planning for problems, it ends up being much, much better. So really walk a mile in their shoes, map the workflow, confirm, measure, improve, measure. You have to keep going back to that workflow. Is the team optimized for telehealth? What we're seeing is that team-based care is falling by the wayside, and it's usually often the clinician just doing the visit. And we're not having the team do pre-visit planning, identifying and addressing those preventive and chronic gaps in care. So is the care team optimized for telehealth? Early in the pandemic, I had the pleasure of talking to Dr. Shoma Stout, and she asked the question, how do we create virtual wraparound teams? It's a really, really good question. And at your organization or at the place that you receive your care, how would you grade them on that virtual wraparound team? We have so many options to improve. What we also see is that huddling pre-clinic is falling by the wayside. I don't know why. I think now that we can all meet virtually, there's no reason that we shouldn't be huddling. So in the in-person pre-pandemic time, we couldn't huddle because what honestly happened was support staff like MAs and nurses and reception staff were there ready to go, but clinicians would slide in at the last minute or like right before their appointment time, and we didn't have time to huddle. You know what? Now there's no excuse. Join a group call. Like even if you're driving in, we can continue to do huddling because it is key to having person-centered care. And how do we know what we can do better? Why I would love it if we would start treating primary care like the hospitality industry. And when we see patients, just ask them, how was your visit? How was your telehealth visit? What could we have done better? Just like when you check out of a hotel, they ask you, they want that feedback. And instead we send paper surveys or CAP surveys, and we lose this opportunity to get feedback on how we're doing and how we can make our healthcare services delivered by telehealth or virtual means more person-centered. If we don't ask, we'll never know. If we don't know, we can't make changes and we can't improve. So I encourage you to collect feedback on best practices, hardwire the changes, make sure if you're going to solicit feedback that you're actually going to make changes. I feel like that's a little bit of an elevator speech, so I apologize if I got a little passionate about that. So the day of the telehealth visit, so what person-centered information do we need at our fingertips before we start that visit? A lot of clinicians won't even look at the patient's chart, and they'll kind of figure things out on the fly. That's not really the best. Even for a telehealth visit, you don't want to be looking at the patient chart and sorting out, now what problems do they have? And then when was the last time they had their pneumovax? And do I need to be screening for colon cancer? Let's see if I can find that report. That is not good form. So, what do we need at our fingertips before we start it? Have we already established that they have what they need for telehealth super important. Are there any accommodations that we need to make for them? Are they hearing impaired? Do we need to make sure that we speak slowly and clearly and loudly? And for our elderly patients, you'd be surprised for how many that actually is the case. How proficient are they? You know, have they successfully attended a telehealth visit before? Know and address the gaps in care, of course, and know what their copay or out-of-pocket expenses are. Back in June, I had a telehealth visit with my PCP, and I think the world of him. I've known him since he was a student applying to our family medicine residency program. But when I asked him, how do I pay my copay? Do I have a copay? He did what most of us clinicians do. We just kind of shook our head and go, oh, I don't know. That's not stuff that I know. I'm a clinician. I know how to like diagnose and treat. Don't ask me about copays and financial stuff. Try to not have that be the experience for individuals seen at your clinic or with your providers. You know what the copay might be, or what the deductible might be, or what the out-of-pocket expense might be, and how to pay it. So we heard from Dr. Pendergrass, who is a nurse practitioner in Utah, and at one of our echo sessions, she was our case study, and she was trying to gather the wisdom of the crowd, like, how are you guys collecting copays? Because we had an in-person system. And now that we're doing telehealth, like, how do we do that? And so make sure that piece is sorted. It's much more person-centered for the patient. And it's a nut to crack for you. So during the telehealth visit, so here's the kind of the techno-human stuff. Clearly identify each member on the care team for the patient. So when, we were making our little chit chat before the webinar, and we were talking about this, that even in the in-person world, and Nikki, I'll call on you to say just another word about this as well, because we chatted about it, and it would be nice for somebody to hear another voice. So just a heads up warning. Even when we're in person at an in-person visit, we need to identify who's who on the care team. Patients shouldn't have to look at the tiny little font on the badge on your chest that might be turned the wrong way because they don't know who you are, or they know they should know you, but they don't know your name, so they're embarrassed. And it's always hard. You don't want to lose eye contact with somebody. They're talking to you, and you're like frantically looking. Who is this? Is this the doctor? Is this the PA? Is this the nurse practitioner? Who is this? Really important on your telehealth visit. And how are you going to do it? Like, just because you show your badge on your white coat doesn't mean the patient knows who you are. So introducing yourself. Hi, I'm Trudy. I'm your physician assistant. I'll be doing your visit today. Nikki, anything to add to that?
Nope, I think you got it, Trudy. Just really that importance of introducing yourself and your credentials if you're an MA or you're the RN or the provider, because the patient doesn't know that in their home. So you nailed them all on this list, I'm pretty sure. And if anybody else has any that they think of that aren't mentioned here, please throw it in the chat box.
Yes, and if they don't know who you are, they want to tell you what's wrong with them, and they'll start telling the MA because they think the MA might be their PCP if they don't know who he or she is. And then it's kind of weird. You're like, then you see your PCP, and the patient is like, but I just told the other person I thought that was my PCP. So it's just awkward. And so just sort that out. Consent, who's going to do it? How is it going to be documented for telehealth? If they're a Medicare patient, it's required. If you are a Medicaid patient, each state has their requirements. The Center for Connected Health Policy has an amazing website. If you don't know what the consent requirements are for your state, it's one of my favorite sites. I go to it all the time, and what each state requires for consent is on that list. Documentation, how are you going to do it? So this is a great role for training scribes internally. Do you have 2 screens? Most practices are providing their clinicians with 2 screens because otherwise it's just impossible to try to look at the patient, pay attention, have good eye contact, and document in the EHR. The camera, how's the camera placement? Explain to the patient what's going on. And that's a pro tip from our patient advisors. Background, what is the patient seeing and hearing? So if you're at your home, maybe your unmade bed in the background is not the best, and maybe you actually should use a Zoom background. Just think about like, what is it that they're seeing or they're hearing? Do you have kids in the background or not? Do a mic and a sound check for both parties, of course. Make sure that you have that stable internet connection and a backup plan if not. So I'm a teleworker. I've been a teleworker for 11 years, but I have to pay for that extra super duper internet. Otherwise, I actually can't get my job done. Make sure you have on-hand support and plan for all techno problems, because when you're a clinician or a care team member, or even on a patient side, it's scary and anxiety provoking if things aren't working, and acknowledge when others people speak. So this is another pro tip that we've heard from our patient and family advisory council is that when a patient speaks, rather than just asking the next question, acknowledge what they said and maybe even paraphrase a little bit, because we don't have those visual cues. And it's a small but important little piece. Quality assurance, different from quality improvement. So quality assurance is basically, how do we make sure that every patient has the highest quality telehealth visit? There are a lot of ways to kind of sort that out. One of the most successful models is having your telehealth super user join a call, and then after the call, you have a little debrief, and your super user or peer reviewer will tell you what went well, what did not go so well, and what maybe you could change to make it better. Also asking patients how it went. Also, I find that it's really important. Engaged leadership is super number one, as we always say, but I'm always curious about the telehealth perspective. And I think it was Anita who said that, the telehealth perspective of her clinician may have been a reason for her to change. And we've also heard about that from other patients. Like if your organization is not offering telehealth, they'll go to another organization that does offer telehealth. And I see some who see this as an amazing opportunity to expand access, to keep patients safe, and we're going to keep it going beyond the public health emergency. But there are other organizations that are just like, oh my gosh, I can't wait to get back to in-person visits. Like, oh, this is like just a stopgap. And that makes me really, really sad when I hear that, but I hear it more than you might expect. And we talked a little bit about inequity and barriers, and that can affect the quality assurance and training. So in the state of Washington, if you provide telehealth visits and you are not an MD or a DO, you have to get telemedicine training. And I'm just going to do a shout out to the NRTRC training. This past weekend, I took the training for Washington State. It's free to anybody. You don't have to, it's free. And last time I heard, they had something like 8,000 people enrolled and close to 6,500 completers. I took it, and it was a little Washington specific. It was awesome. It was just clear and straight to the point. And they are developing one that is kind of a general telemedicine 101. And it's just really, really great. And I'm hoping that the link was pasted into chat. And I just want to turn it over for a few seconds for anyone on the NRTRC staff to fill in any gaps that I may have left with your training program, which I think is awesome. Loved it.
Thanks, Trudy. So Jillian just put the URL in the chat box. You can also get it from the NRTRC website. But as Trudy said, the state of Washington passed a bill mandating that any licensed healthcare professional take a telehealth training course. And so the NRTRC worked with the Washington State Telehealth Collaborative and the University of Washington and the Behavioral Health Institute at Harborview to create this education. The courses are about 20 minutes in length, and they're very high level, but they touch on all of the pieces necessary for a telehealth visit from a clinician's standpoint. And upon successful completion, you can print a certificate of your attendance. As Trudy said, you do not need to be a resident of Washington, and it's a really good starting place. So that link is in chat, and if anybody has any questions, feel free to reach out afterwards.
Excellent, thank you. Doing a time check, we have about 5 more minutes. I'm always surprised at how an hour can get filled up so quickly. I feel as though it took me a couple slides and minutes to hit my stride. So apologies if I was a little hesitant at first, but clearly I've hit my stride. So I think the key takeaway for today is really acknowledging that we have blind spots about how we can be more person-centered and really put ourselves in our patients' shoes, our users' shoes, our individuals' shoes, our staff shoes, to make changes that are going to make things better, because we have a lot we need to smooth out. And there's, the person-centered side of telehealth billing. I am really sensitive to the fact that a lot of patients don't know that they have to pay, or the clinician is unprepared. Most clinicians don't have practice management in their residency or PA or nursing training. So, we have opportunities to improve, know what the requirements are for your state Medicaid, make it easy to pay those deductibles and copays, let them know in advance what it's going to be. We have opportunities to improve. In Utah, for example, part of informed consent is you have to let the patient know about any additional fees. This is a requirement, and each state, as I said, is a little bit different. And so we have very little time for questions and discussion, but I'm still going to open it up. And while we have any questions, I do want to promote the upcoming events of the NRTRC. There you are. And any comments, questions in the few minutes that we have left?
Before anybody else jumps in, David, I just saw your message in the chat box, and the one piece I left out about the telehealth training is one of them is specific to behavioral health. So if you go to the www.nrtrc.catalog.instructure, it's the Behavioral Health Institute course, and there will be 6 courses in completion for telehealth, for behavioral health and mental health. And if nobody else has any comments, I just want to say thank you to Trudy and Comagine Health. The NRTRC really appreciates your partnership and your engagement. And I want to say thank you to everybody for attending today. Trudy will be sending out an email with the slides in case you want to share with some of your colleagues, along with a patient-facing handout. And as always, if you have any questions or comments or feedback about additional office hour topics you'd like to discuss, please let us know. And I think that's it. Thank you for your time.
So Nikki, as people are signing off, we had thought maybe we would have a little time to share that patient-facing resource. We wanted that best-of-breed resource. And when I looked for that best-of-breed resource, some of them have good pieces but none of them are perfect. So we designed a resource de novo. Many thanks to the NRTRC and especially Nikki for weighing in on it. So we will send it, but it is not perfect. And as we are always trying to improve, if you can think of other ideas or things that should be on that sheet, please let us know. And I'm doing a time check, and we are 1 minute before. So officially closing our webinar. Thank you so much to everyone for attending.